So this one's going to be a little longer. We're going to be covering anticoagulants, antiplatelet agents, and thrombolytics. Not going to worry about this picture. There's too much going on. So thrombosis and clot removal. So first we're going to start off with what forms clots. Arterial thrombosis, or a local injury. First, the platelets adhere to collagen, causing platelet aggregation. Second, platelet plug is reinforced by fibrin or coagulation. Venous thrombosis is the next step for a distal injury. The first, stagnant blood flow initiates clotting cascade and fibrin production. Second, the fibrin network catches RBCs and platelets to form a clot. A long tail forms, which may break off and become an embolus. For clot breakdown or prevention, there is clot inhibition, which antithrombin binds and inactivates IXA, XA, XIA, XIIA, and thrombin, and clot removal, which plasminogen activated to form plasmin, which dissolves clots. Here's a nice picture of a blood clot. Three major categories of drugs for thromboembolic disorders. Anticoagulants disrupt coagulation cascade and suppress fibrin formation. They prevent venous thrombi. Antiplatelet drugs inhibit platelet aggregation to prevent arterial thrombi. Thrombolytic drugs activate plasminogen to form plasmin. They lyse fibrin and dissolve thrombi. Anticoagulants are going to be heparin, sub-Q or IV. This deactivates thrombin and factor XA. Low molecular weight heparin. This is done sub-Q and deactivates factor XA. This is called enoxaparin or Lovenox. Warfarin or Coumadin is done orally and decreases synthesis of vitamin K dependent clotting factors. This interacts with VII, IXX, and prothrombin. Direct thrombin inhibitors inhibit thrombin. This is dabigatran, etexylate, mesylate, or Pradaxa. You want to take this orally. Direct factor XA inhibitors inhibit factor XA. This is rivaroxaban or Xarelto. This is taken orally. Apixaban or Eliquis, which is orally. And the suffix for these are exaban, hence bans factor. So this ban, a hint for this to remember is it bans factor XA, exaban. Heparin, the first drug we're going over. The mechanism of action is it enhances antithrombin's ability to deactivate thrombin and factor XA. This prevents conversion of prothrombin to thrombin and conversion of fibrinogen to fibrin. This increases clotting time, prevents further thrombus formation, does not dissolve clots. It's used for venous thrombi. Which of the following statements about heparin is true? Heparin decreases synthesis of clotting factors and prevents venous thrombi. Heparin, high molecular weight anticoagulant. It deactivates factors in bloodstream, only binds to antithrombin to deactivate factor XA. This binds to antithrombin and thrombin to deactivate thrombin. Heparin, high molecular weight anticoagulant. The use for it is it prevents thrombus during surgery, postoperatively, and during hemodialysis. It is a rapid anticoagulation. Deep vein it can also be used for a rapid anticoagulation, deep vein thrombus, pulmonary embolism, evolving thrombotic stroke, acute myocardial infarction, disseminated intravascular coagulation, or DIC. It is a long polysaccharide chains with pentasaccharide 5-sugar sequences. It's highly polar, cannot readily cross membranes due to multiple negative charges. It is used in pregnancy and lactation, not absorbed orally, does not cross the placenta or enter breast milk. The use for high molecular weight anticoagulant heparin is venous and atrial thrombi as an adjunct. Rapid acting within minutes, IV. Given IV or sub-Q, not IM, because it'll cause hematomas. It's not absorbed orally. Variable free heparin levels, bind to plasma and tissue proteins, starting the dose based on weight, subsequent dosing based on partial thromboplastin times, APTTs. Metabolism in the liver, and it is 1.5 hours half-life. Excretion is renal. Laboratory monitoring with heparin. The goal is decreased coagulation without spontaneous bleeding. It is activated partial thromboplastin time, APTT. Goal is 1.5 to 2 times control value, which is 60 to 80 seconds. Normal is 40 seconds. Dosage based on PTT. Every 4 to 6 hours, initially every day once dose established. Monitor due to variable blood levels. Adverse effects of heparin. Hemorrhage occurs in 10% of patients. Treatment is protamine sulfate. This has an immediate onset, lasts 2 hours, and may need to repeat the dose. 1 milligram binds to 100 units of heparin. Give slowly IV, 20 milligrams per minute or 50 milligrams per 10 minute. Decrease risk of bleeding. Keep activated partial thromboplastin time less than or equal to 2 times the control. Monitor for signs of bleeding and screen for risk factors. Avoid antiplatelet drugs such as ASA and clopidogrel or Plavix. There is a hypersensitivity reaction due to contaminants, and it is since heparin is extracted from animal tissue. Hypersensitivity reactions could include chills, fever, urticaria, and anaphylaxis is rare. Osteoporosis with long-term treatment of heparin, and if it is high dose. How do you know if your patient is bleeding? They should have any of these signs or symptoms or lab results. Heparin-induced thrombocytopenia or HIT. Potentially fatal disorder in 0.2 to 5% of patients using heparin, less than 4 days. Antibodies against heparin and platelet protein complexes. They damage the vascular endothelium, activates clotting and reducing platelet count. So you want to monitor platelet count and stop if less than 100,000. Check 2 to 3 times for a week for 3 weeks. Monitor for signs of thrombosis. And these signs would be a DVT, a PE, an MI, or cerebral thrombosis. Discontinue heparin and use non-heparin anticoagulant, which would be a direct thrombin inhibitor, such as argatroban or Acova. Heparin preparations. It's prescribed in units, not in milligrams. Dosing, multi-dose vials, single-dose vials, and unit-dose preloaded syringes. 1,000 to 20,000 units per ml. Heparin locks to keep IV catheters patent. Central lines falling out of favor due to HIT. HIT is heparin-induced thrombocytopenia. 10 or 100 units ml, and no systemic anticoagulation. Heparin cautions and contraindications. Cautions are going to be hemophilia, increased capillary permeability, dissecting aneurysm, peptic ulcer disease, severe hypertension, threatened abortion, and severe liver or kidney disease. Contraindications for heparin are thrombocytopenia, uncontrollable bleeding, surgery on the eye, brain, or spinal cord, and lumbar puncture or regional anesthesia. Heparin administration for IV, we want to rotate the IV site every 2 to 3 days. Initial bolus followed by continuous infusions. The initial bolus is about 5,000 units, followed by 20 to 40,000 units over 24 hours. You want to check APTT every 4 to 6 hours, and use an IV pump and check the rate every 30 to 60 minutes. For subcutaneous, we want to rotate sites in the lower abdomen 2 inches from the umbilicus. No rubbing or aspiration of the site. You want to use a needle that is a 1/2 to 5/8 inches. That is also a 25 to 26 gauge. You want to use firm, gentle pressure for 1 to 2 minutes afterwards. You also want to check your dose with another RN. While administering heparin, to your patient, you would do which of the following? Use firm, gentle pressure after administration. Low molecular weight heparins. Example is going to be enoxaparin or Lovenox. Uses are they are as effective as heparin and can be used at home. Unlike heparin, it is now the first line drug. You can prevent and treat DVTs with joint and abdominal surgeries, prevent ischemic complications from angina and MIs. The mechanism of action for low molecular weight heparins is it binds to antithrombin to deactivate factor XA, small effect. Very little inactivation of thrombin, fragments not long enough to bind to antithrombin and thrombin. Longer half-life, better bioavailability, sub-Q, can give 1 to 2 times a day, no binding to plasma proteins and tissues, and it does not need PTT monitoring, and it is dosed on indicator. It is also dosed on body weight. It's a fixed daily dosage drug. Adverse effects for low molecular weight heparins are bleeding. You want to use you want to use protamine sulfate 1 milligram per 1 milligram of enoxaparin or Lovenox. May also cause severe neurological injury if bleeding compresses the central nervous system, such as a spinal puncture, epidural, or spinal anesthesia. And it can also cause thrombocytopenia, but it is less than unfractioned heparin. Heparin and low molecular weight heparin drug interactions. So for bleeding, drugs that inhibit hemostasis, such as ASA, antiplatelet drugs, anticoagulants, or fibrinolytics, and drugs that cause ulcers, such as ASA, NSAIDs, and glucocorticoids. Oral anticoagulant warfarin. Mechanism of action for this is it interferes with synthesis of vitamin K dependent clotting factors such as 7, 9, and 10 plus prothrombin. This inhibits enzymes that activate vitamin K epoxide reductase complex 1, VKORC1. A variant gene for VKORC1 may increase sensitivity to warfarin. There are no effect on pre-existing clotting factors. The effects are going to be initial response in 8 to 12 hours, but that is not the actual effect. There are still clotting factors circulating. This is not used for rapid anticoagulation and must use another anticoagulant until the INR is in therapeutic range from 3 to 4 days. Anticoagulant levels last 2 to 5 days after the discontinuation of the drug, and it prevents venous thrombosis. Uses for warfarin is to prevent and treat DVT and PE or pulmonary embolism, and prevent thromboembolism with mechanical heart valves or atrial fibrillation. This also decreases risk of recurrent TIAs or MIs. It's so well absorbed orally, and it is highly protein bound, 99%. Unbound warfarin crosses placenta and enters breast milk. It is a category X for pregnancy, not recommended for lactation. It is metabolized by CYP2C9. The variant gene for CYP2C9 decreases its metabolism and increases blood levels. There is testing available for this. It is excreted through the kidneys and feces. Warfarin laboratory monitoring. Usual dosing initial is 2 to 5 milligrams a day. Maintenance is 2 to 10 milligrams a day. You want to check the international normalized ratio, or INR, because this accounts for variation in thromboplastin type. The goal for INR is 2 to 3. Usually some patients are 2.5 to 3.5. INR is 3 to 4.5 for mechanical heart valves. And you want to measure it daily, twice a week, weekly, and then every 2 to 4 weeks. It's measured when warfarin dose is changed or other drugs are added or deleted to regimen. And you can measure this with home devices. The adverse effects of warfarin for bleeding, it's gene variations for VKORC1 and CYP2C9 may increase the risk of bleeding. You can treat an overdose of warfarin with vitamin K, IV or orally, 0.5 to 1 milligram IV diluted, or 2.5 milligrams orally preferred. You may get anaphylaxis from the IV route, so give it slowly. You can also give fresh frozen plasma or concentrated vitamin K dependent clotting factors. You want to stop warfarin several days prior to surgery, vitamin K injections before emergency surgery. Risk of fractures. is it leaves bones weakened with 12 months usage. Warfarin cautions and contraindications. Cautions are going to be hemophilia, increased capillary permeability, dissecting aneurysm, GI ulcers, severe hypertension, and anticipated abortion. Contraindications are active bleeding, severe thrombocytopenia, decreased synthesis of clotting factors, and this will happen through alcohol, vitamin K deficiency, or liver disease. For any surgeries that are eye, brain, or spinal cord, those are contraindications for warfarin, lumbar puncture, or regional anesthesia, and if they are pregnant or lactating, that is a contraindication. Warfarin drug interactions, there are increased warfarin levels through warfarin being displaced from albumin through aspirin and sulfamides. Warfarin metabolizes inhibited acetaminophen or Tylenol, sulfonamides, and azole antifungal drugs. Other things have a decreased effect on warfarin, such as an accelerated metabolism of warfarin through carbamazepine, phenobarbital, phenytoin, and rifampin. You can also get increased synthesis of vitamin K dependent factors, vitamin K through vitamin K or oral contraceptives. There's also inhibited warfarin absorption through bile acid sequestrants. Drug interactions continued for warfarin. Drugs that promote bleeding, such as aspirin, antiplatelet drugs that inhibit platelet aggregation, heparin, which inhibitates coagulation, and aspirin, NSAIDs, and glucocorticoids, which cause GI ulcers. Warfarin food drug interactions. Foods high in vitamin K, such as green leafy vegetables, spinach, kale, lettuce, turnip greens, cabbage, watercress. Iceberg lettuce is generally okay. Peas, asparagus, broccoli, green tea, oats, whole wheat, mayonnaise, canola oil, and soybean oil. You need a consistent diet. Contrasts among anticoagulants. So for heparin, the action is it promotes action of antithrombin and inactivates thrombin XA through venous. Route is going to be IV or sub-Q. Onset is rapid in minutes. Duration is brief for hours, and you want to monitor PTT. Antidote is going to be protamine. Pregnancy and lactation, yes. For LMW heparins, the action is it promotes action of antithrombin, inactivates XA venously. Route is sub-Q, may be given IV prior to some procedures. Onset is about 3 hours. Duration is six times longer than heparin. Monitoring, there is none needed based on weight, not protein bound. The antidote is protamine, and you can use it during pregnancy and lactation. Warfarin differs. The action is going to be it inhibits synthesis of vitamin K dependent clotting factors such as 7, 9, 10, and prothrombin. And this is venous. Route is going to be orally. Onset is slow, 8 to 12 hours due to current clotting factors. Duration is prolonged for days. Monitoring is going to be PT and INR. Antidote is vitamin K1. And you cannot use this if you're pregnant or lactating. Your patient with atrial fibrillation is receiving an anticoagulant that inhibits the synthesis of clotting factors, which therapeutic laboratory range would you strive for? You want to strive for an INR of 2 to 3. Choose the correct agent used to reverse the following medication. You want to choose a low molecular weight heparin because they are reversed by protamine. Dabigatran or Pradaxa is an oral direct thrombin inhibitor. Related drugs are bivalirudin, argatroban, which is done through a continuous IV, and desirudin, which is done subcutaneous. Uses are they prevent stroke and emboli with non-valvular atrial fibrillation. The mechanism of action are direct inhibition of thrombin. This reversibly binds with thrombin in clots and serums, prevents creation of fibrin and activation of factor VIII. Advantages over warfarin is there's less bleeding, rapid onset, no blood work, fewer drug-food interactions, and fixed dosing. Disadvantages over warfarin is it causes more GI distress, limited clinical experience, and must take twice a day and on time. Reversal agent for dabigatran is dialyze recombinant factor 7 or factor 9 complex. You want to give ibaruzumab, which produces a rapid reversal, 2.5 grams intravenously if healthy, 5 grams IV if elderly or renal insufficiency. Dabigatran, oral, the pharmacokinetics for this is it is a well absorbed with or without food, low protein binding and no hepatic metabolism. Monitor renal excretion, may need to reduce dose or hold. Adverse effects are going to be bleeding, dyspepsia, gastric-like symptoms. Consider proton pump inhibitor or histamine 2 receptor antagonists. Taking with food may diminish GI adverse effects, but it also slows the absorption. Stop 1 to 2 days before surgery. Dabigatran drug interactions. You want to avoid P-glycoprotein inhibitors that increase drug levels, such as ketoconazole, amiodarone, verapamil, and quinidine. P-glycoprotein inducers decrease drug levels, reducing beneficial effects such as carbamazepine, phenobarbital, rifampin, and St. John's wort. Bleeding increases with other drugs that affect homeostasis. You want to store in a bottle with desiccant cap, unstable with moisture. Administration should be at least 6 hours apart. Dose on time. Consider taking with food. Do not crush, chew, or open capsules. This causes an increase of absorption and may lead to bleeding. Now we're moving on to ribaroxaban, direct factor XA inhibitor. The uses is it prevents DVT and pulmonary embolism in joint replacements, prevents stroke with non-valvular atrial fibrillation, and prevents and treats DVT and PE unrelated to orthopedic surgery. Mechanism of action is it inhibits factor XA in clots and serums, and the advantages over warfarin is less bleeding, rapid onset, no blood work, fewer drug interactions, fixed dosing, and once-a-day dosing. Disadvantages over warfarin is limited experience and must dose on time. It treats bleeding with activated charcoal, recombinant factor VIIA, and prothrombin complex concentrates, PCCs, or activated PCCs. Reversal agents for ribaroxaban and apixaban are andexanate alpha. You want to give 400 to 800 milligrams as rapid bolus over 2 to 5 minutes, followed by 2-hour infusion of 480 to 960 milligrams. Rivaroxaban or Xalerto, direct factor XA inhibitor. The pharmacokinetics is it is absorbed with or without food. It is highly protein bound, eliminated in urine and feces. Drug interactions is inhibitors of CYP3A4 or P-glycoprotein increases blood levels. The azole antifungal drugs, HIV protease inhibitors, and macrolides, diltiazem, verapamil, and amiodarone are inhibitors of CYP3A4, and they increase blood levels. Carbamazepine, phenytoin, rifampin, and St. John's wort induce CYP3A4 and P-glycoproteins, but they decrease the blood levels. Do not use with anticoagulants. Caution with antiplatelet agents and fibrinolytics. Warnings are elevated levels with hepatic or renal disease. Stop 18 hours before you pull epidural catheter and then wait 6 hours to restart. Unsafe. These drugs are unsafe in pregnancy. Apixaban or Eliquis, direct factor XA inhibitor. Use is prevention of stroke, systemic embolism with non-valvular atrial fibrillation. Mechanism of action is it inhibits factor XA in clots and serum and inhibits prothrombinase, preventing thrombin production. The pharmacokinetics for apixaban, it's highly protein bound, eliminated by urine and feces. Careful with renal impairment. The advantages over warfarin is less bleeding, rapid onset, no blood work, fewer drug interactions, and fixed dosing. Disadvantages is there's limited experience. You need to dose twice a day and must dose on time. There is a risk for hemorrhage in pregnancy and delivery. Treat bleeding with recombinant factor VIIA, prothrombin complex concentrates, PCCs, or activated PCC, and dexanate alpha. Properties of oral anticoagulants. Warfarin mechanism is decreased synthesis of vitamin K dependent factors. Onset, days or prolonged. Antidote is vitamin K. Drug food interactions, many. INR for dosing, yes, just a dose. Adjust dose. Doses, 1 a day. Clinical experience, extensive. Other advantages, the dose timing is not critical. For rivaroxaban, mechanism is inhibition of factor XA. Onset and duration is hours and short. Antidote is andexanet alpha. Drug food interactions is few. INR for dosing is no. Fixed dose. Doses a day, 1. Clinical experience limited. Other advantages, less bleeding and hemorrhagic stroke. Other disadvantages, you must dose this one on time. Apixaban mechanism is inhibition of factor XA. Onset and duration is hours and short. Antidote is same as rivaroxaban, which is andexanet alpha. Drug food interactions is few. INR for dosing is no, since it is a fixed dose. Doses a day is 2. Clinical experience is limited. Other advantages, less bleeding and hemorrhagic stroke, but you have to dose this on time for a disadvantage. Next is dabigatran etexylate. The mechanism is direct inhibition of thrombin. Onset and duration is hours and short. Antidote for this one is Praxbind or ibaruzumab. Drug food interactions is few. INR for dosing, no, it is a fixed dose. Doses a day is 2. Clinical experience is limited. Advantages are less bleeding and hemorrhagic stroke. And other disadvantage is you have to dose this on time. There are common GI disturbances that come with it. Antiplatelet agents, aspirin and cyclooxygenase inhibitor, P2Y12 adenosine diphosphate, ADP receptor antagonists, glycoprotein GP2B and 3A receptor antagonists. They use arterial thrombi. Platelets core constitutes the bulk of an arterial thrombus, and they suppress platelet aggregation. Aspirin is an antiplatelet agent. The uses are for strokes, TIAs, chronic and unstable angina, coronary stents, acute and previous MI, and MI prevention. Mechanism of action is it suppresses platelet aggregation, COX-1, and vasoconstriction by inhibiting COX-2. This is irreversible and lasts 7 to 10 days. The dose is initial 325 milligrams daily and maintenance of 81 milligrams daily. Adverse effects are GI bleeding and hemorrhagic stroke. The next is going to be clopidogrel or Plavix, which is a P2Y12 ADP receptor antagonist. Use for this is risk reduction for patients with atherosclerosis, such as stents, MIs, ischemic strokes, or vascular death. Mechanism of action is it blocks ADP receptors on platelets and prevents aggregation. Has a small effect, blocks only one trigger for aggregation. It is irreversible and lasts 7 to 10 days. It is a prodrug needing CYP2C19 to activate the drug. Some may have a variant gene that prevents activation. Given with ASA, 75 to 325 milligrams daily for acute coronary syndrome. ASA is aspirin. Clopidogrel Plavix continued. Adverse effects are bleeding less than aspirin. Discontinue 5 days before surgery. Abdominal pain, dyspepsia, and diarrhea. Rash, thrombocytopenia purpura, TTP in first 2 weeks. Thrombocytopenia, hemolytic anemia, rash, fever, renal dysfunction, and neurological disturbances are along with that TTP. You want to avoid CYP2C19 inhibitors, such as amiodarone, fluoxetine, fluoxetine, or Prozac, fluconazole or diflucan, ketoconazole or nizoral, and etc. These are proton pump inhibitors, and they may inhibit CYP2C19 and prevent activation of the drug. You want to give with pantoprazole, Protonox, only if at risk for a GI bleed, and caution with drugs that promote bleeding. Glycoproteins, or GPs, 2B and 3A receptor antagonists. Examples are abciximab, tirofibon, and eptifibatide. Uses are acute coronary syndrome, percutaneous coronary interventions, usually given with aspirin and low-dose heparin. Mechanism of action is it blocks glycoproteins 2B and 3A receptors to prevent fibrinogen bridges. This has a large effect. It is reversible. It is the final step in platelet aggregation. Adverse effects are bleeding, no increase in fatal hemorrhaging, or hemorrhagic strokes. Protease activated receptor 1 antagonists. Examples are vorapaxar or Zontivity, used in conjunction with aspirin or clopidogrel. Uses are it reduces thrombotic events in patients with a history of MI or PAD, reduces rate of CV death, MI, and strokes. Mechanism of action is it inhibits thrombin-induced platelet aggregation, hepatic metabolism, and excreted in the feces. Adverse effects is bleeding. So these are going to be your properties of selected antiplatelet drugs. So first we're looking at cyclooxygenase inhibitors. The drug represented is aspirin. The mechanism, it is irreversibly blocks cyclooxygenase, blocking synthesis of thromboxane A2. This blocks COX-1 inhibits platelet aggregation and blocks COX-2, which vasoconstricts. Route is oral. Duration of effects is 7 to 10 days. Next is PY12 adenosine diphosphate, ADP receptor blockers. The drug represented is clopidogrel or Plavix. This irreversibly blocks receptors for ADP. This route is oral, and it is 7 to 10 days duration if clopidogrel or Plavix. Next is glycoprotein GP 2B and 3A receptor blockers. The drug for this is tirofibin or aggrastat. This reversibly blocks receptors for GP 2B and 3A. Route is IV infusion. Duration of effects is 4 hours after stop infusion. Next is protease activated receptor 1 antagonists such as vorapaxar or Zontivity. Mechanism is it inhibits thrombin-induced platelet aggregation. It is given orally, and the effects persist for 7 to 10 days after drug withdrawal or until new platelets have been synthesized. Let me pull up the question. Your patient has been prescribed an ADP receptor antagonist, clopidogrel, Plavix, to reduce his risk for ischemic stroke. He wants to know how it works. You state the following. It prevents arterial blocks. Adaplase, or tissue plasminogen activator, TPA activase, is a thrombolytic drug, fibrinolytic. The uses are for acute MI, acute massive pulmonary embolism, or ischemic stroke within 4 to 6 hours of symptom onset. Suffix is ASE, similar to drugs Retaplase or tenecteplase. Mechanism of action is it activates plasminogen to plasmin. Plasmin dissolves the fibrin network and degrades fibrinogen and clotting factors. This breaks down clots. It has a 5-minute half-life, given IV over 90 minutes, and it is gone in 10 minutes. Risk of serious bleeding, especially intracranial hemorrhage. There is an increased risk with anticoagulants, antiplatelet drugs, NSAIDs, and etc. Avoid needle sticks and invasive procedures. Pressure dressings on cutaneous puncture sites. Reversal with whole blood, packed red blood cells, and fresh frozen plasma. Aminocaproic acid, Amicar, prevents activation of plasminogen. Thrombolytic drugs or fibrinolytics, contraindications. Absolute are history of prior intracranial hemorrhage, structural cerebral vascular lesion or cerebral vascular disease, ischemic stroke within 3 months, except if within 4 to 5 hours, intracranial neoplasm, internal bleeding, except menses, aortic dissection, and acute pericarditis. Relative contraindications, a BP above 180 or 110, above 180 over 110. This is or poorly controlled blood pressure, ischemic stroke within 6 months, dementia or other cerebral pathology, anticoagulants or bleeding disorder, non-compressible vascular puncture, trauma or CPR over 10 minutes, major surgery less than 3 weeks ago, recent internal bleeding within 2 to 4 weeks, or active peptic ulcer disease, or pregnancy. The major risk with thrombolytic drugs are bleeding. So you want to monitor for bleeding, such as decreased blood pressure and increased heart rate, CBC, platelet counts, PTT, PT, and INR counts, bleeding gums, bruises, petechia, hematomas, red or black stools, discolored or cloudy urine, pelvic pain or in the ovaries, headache, faintness, weakness, dizziness, this is the brain, and lumbar pain, which is the adrenal gland. Patient education, you want to have bleeding precautions such as electric razors, soft toothbrushes, and avoid contact sports. Look for signs of bleeding. Also, some dietary considerations: warfarin, consistent vitamin K intake. Avoid alcohol, reduces clotting factors. Coumadin, there is a risk to fetus and infant. Notify other healthcare providers. Stop medications a few days before elective procedures. Check with provider for number of days. Management of missed warfarin doses. Do not double dose. Get INR and determine the dosage you need. Patient education continued. You want to check with pharmacists before taking any over-the-counter drugs or new antibiotics. Avoid NSAIDs because they may cause ulcers. Consider H2 receptor antagonists or proton pump inhibitors, but be careful with clopidogrel or Plavix. Non-drug measures are to avoid prolonged immobility, elevate and move legs while sitting, avoid garments which restrict blood flow, participate in exercise activities, wear support hoses, wear identification bracelet, limit vena punctures and injections, and pressure dressings to recent wounds. The maximum effects of warfarin or Coumadin occur within 3 to 4 days. Which of the following statements accurately reflects the differences between traditional heparin and low molecular weight heparin? Low molecular weight heparin yields a predictable dose response. And the difference between anticoagulants and thrombolytics is that thrombolytics dissolve clots where anticoagulants prevent additional clot formation. And that will be it for this presentation as well.